Hi guys, I'm Dr. Bhushan Jade, Chief Consultant and Director, Department of Radiation Oncology, Ruby Hall Clinic, Pune. So today we talk about breast cancer and radiation therapy, how radiation therapy is important in breast cancer and what care patients should take during the radiation therapy course. A general information about this topic we'll discuss today. So breast cancer, as we all know, is one of the most common, I would say most common cancer in females in urban population, and in rural population also the incidence of breast cancer is rising because of the lifestyle changes. We can discuss a lot about why the breast cancer is rising, but let us not discuss that today because that's not our topic. So we'll restrict ourselves to the radiation therapy and how it is important in breast cancer management. So breast cancer needs surgery, needs radiation therapy, needs chemotherapy and other targeted hormonal therapy as a treatment modality depending upon what type of breast cancer we are treating. So sequencing may change. Sometimes the tumor is big, patient needs chemotherapy to downstate the disease, then comes surgery, then comes radiation. Sometimes patient may get diagnosed with a small tumor where surgery is first, followed by chemotherapy if required depending upon the report of the patient, histopathology report, and then comes radiation, and then comes hormonal or other treatments. So these three, surgery, chemo and radiation, these are most important along with the other modalities of treatment. So when it comes about radiation therapy, typically it is 5 to 6 weeks of course of radiation every day, Monday to Friday, 5 days a week. Treatment holidays on Saturday, Sunday goes for 5 to 6 weeks. But again, this 5 to 6 weeks is little older way of giving radiation. Nowadays, with all the modern data and modern technology, the regimen of breast cancer radiation from 5 to 6 weeks of earlier course has come down to 3 to 4 weeks. Again, which is a standard of care as per the guidelines, as per the Indian acceptance to the guidelines. We are now prescribing radiation for 3 to 4 weeks only. And there is upcoming data, or there are certain conditions where we can reduce the course of radiation to 5 days only. But again, whether patient needs the 5 days of radiation, 15 or 20 days of radiation, or a very conventional old fashioned 5 to 6 weeks of radiation, that depends upon individual patient details, the technology of treatment available at the particular institution, and the expertise of the doctor who is treating the case. So let us keep that as a general range from 5 days to 25 to 30 days. But when it comes to giving radiation, there are few common things. So it starts from consultation in a clinic. So when I see patient in clinic, we need to go through the patient disease profile, what kind of a histology we are dealing with, what is the stage of the patient. After surgery, the complete detailed histopath report, the hormonal receptor status of the patient, other comorbidity. The logistic also plays sometimes important role, where the patient stays, how far is the radiation facility from the patient's home. So these are factors which needs to take into account when we discuss the radiation therapy plan with the patient. So once we are done discussing the plan, the first step of radiation therapy planning is simulation. So we take patient on a couch, make her lie comfortably, give her supports in the form of either slope board or wing board or specialized breast boards. Sometimes we create a customized vacuum bags for the comfort of patient, what we call vac lock. The entire purpose of these devices is to minimize the movement of the patient when she is undergoing radiation therapy on a treatment couch. When we support her with all these kind of instruments or devices, she lies down on a couch comfortably, and the movements which may happen are less, and that improves the accuracy of treatment delivery. So first day we do all these kind of immobilization devices, make her lie down comfortable in a straight line, and then we do the data acquisition scan, what we call a CT simulation scan. Once we acquire all those data, patient may go home, and then we need 3 to 4 working days for our back-end planning. So in our back-end planning, what we do, we identify the target areas depending upon her disease stage, the location of the tumor, which quadrant is involved, whether we are treating the entire breast or whether we are treating the only tumor bed with the margins, what we call the accelerated partial breast irradiation, what protocol we are following. Depending on all these clinical factors, we create a plan. Once the purpose of creating a plan, it to give the prescription doses to the identified target volume, and sparing the adjacent organs to the maximum. So what adjacent organs we are talking about when we treat breast cancer? We are talking about heart, we are talking about lungs, and of course skin. So on a left-sided breast, when we treat, there is a heart which is sitting just below the breast, or what we call the chest wall. So we explore the advantage of deep inspiration. So when we take a deep inspiration like this, our chest expand, and when our chest expand, it goes away from the heart by few centimeters like this, and relax. So we exploit this position in a deep inspiration in a technology what we call deep inspiratory breath hold. So we ask patient to take a deep breath. Of course, deep is very relative word. We have to objectify this deep by putting a sensors on a patient's chest region, and with these sensors we monitor patient's rise in the chest or fall of the chest with the help of infrared markers and the cameras, and then we create a graph. It's very automated technology. We create a graph of breathing pattern like inspiration, expiration. We can see the graph in our console outside the room where the patient is lying down, and patient has a small screen in front of her where she herself can see her inspiratory expiratory pattern. And then with the help of this data, a system creates a zone what we call the deep inspiratory zone. And when we ask her to take a deep breath, she's supposed to take her breath in that region or in that zone and maintain whatever capacity she has got of holding the breath few seconds, like 10-12 seconds, whatever comfortable for her. Even if she takes a breath which is much deeper than needed, sensors identify it is not required, machine goes on hold. If she loses her breath, like she's tired, machine goes on hold. So everything is automated. So we have to counsel the patient that don't worry. Even you take something wrong, like extra deep breath, or you take a little deep breath, nothing will happen. It will take its system will take its own time to recover, and you will be given time again. So nothing will go wrong because everything is automated. So once we counsel and give some training, it becomes very easy for patient to follow this pattern. So deep breath, hold in that region, and we do simulation scan. And similarly, the same protocol we follow on the treatment unit when we deliver the treatment. So it's very simple once we make patient understand. So we acquire all this data. Data goes to system. We identify heart, we identify lungs, we identify the breast volume, the tumor bed for the extra little dose, what we call the boost, and we create a plan which optimizes the best treatment delivery and the least doses going to the normal structures which are there in the region. So once this is done, patient goes for treatment on day 1. So for day 1, patient, everything is new for patient, like machine, people, space. So we have to counsel and ask some coordinator to make her introduced to the people, make her introduced to the machines, the room. And first day we also be present there to see the first setup. And then once the treatment, patient is lying down on a treatment couch, we do a scan, what we call CBCT, cone beam computed tomography scan. We match this scan to the reference scan to see some errors like movements. So we always get to see few millimeters of movement which are very natural, very possible in spite of whatever immobilization devices we use. And these error, these movements we capture in the 6th dimension. So generally these are 3-dimensional movements, but high-end systems like ours, we have a 6th dimension. So typically translational X, Y, and Z, and then we have roll, we have a pitch, and we have a yaw. So this 6 degrees of movement we capture, we apply this correction to the couch. What we have is a 6D couch. It takes all these 6D corrections, and then patient is perfectly aligned with the kind of a plan we have done on the planning system. So alignment is perfect, and then we initiate the treatment delivery so that the delivery is exactly what we have seen on the computer screen. So it takes around 5 to 6 minutes of time. This is very quick because the machines are high dose rate machines. So it's not very uncomfortable for patient, where in olden days patient has to lie down on a couch for 15-20 minutes. Nothing like that nowadays. It's only 5 to 7 minutes. In that, during this process of radiation, patient don't feel anything. It's for them just machine going around here and there. there is nothing to be seen because these x-rays are not visible and they are not kind of giving any kind of a sensation to the human body. So she doesn't feel anything is happening. And this is an everyday treatment. So suppose she has got a 3 weeks of treatment. So first 2 weeks she will not feel any kind of changes happening here, but last week she will feel little reddishness over the radiated skin. This is again a temporary phenomena. Patient has to be counseled. Once they know it's comfortable, it comes like this, and then after treatment is over, it goes like this. So 2 to 3 weeks time, everything will be clean and clear. Only thing, she has to be counseled that do not rub this area, do not scratch, do not apply any oil or any kind of a cosmetics which we generally apply at home. If needed, we will prescribe you some specialized creams which are available in the center, but do not use the home remedies. That's the only thing into counseling. She can take shower, bath, she can clean this area, but gently with hand. Do not use loofah, do not scratch, Then after bath, she should not rub it dry, she just pat it dry. So no, soft sponging is what is needed. So basically you have to be gentle with a radiated skin, and that's it. Very simple to follow once we counsel them in a proper manner. So treatment 3 to 4 weeks, recovery at the most 2 to 3 weeks of time. During this period, no major medication or no supportive medications are required. Only thing what is needed is skin care. Sometimes we give radiation to this area, the supraclav area. When the nodes are positive in axilla, we may tend to give radiation in the supraclav area. There, the esophagus comes little closer, and some scattered dose of radiation may hurt esophagus. So some patients may have problem in swallowing food, some pain here when the food is passing through the esophagus. So those patients may be given some kind of a local anesthetic or some painkiller, but again that incidence is very less in a modern radiation therapy practice. But nevertheless, we have to be cautious about it, and we should counsel our patients that this may happen. So again, in a nutshell, radiation therapy for breast cancer is very evolved, highly modern way of doing radiation. The cardiac toxicity like heart and lungs, they are very, very less. The radiation schedule from 6 weeks has come down to 3 weeks, and now we are again doing some studies and some research where the future treatment of radiation, or even now also few indications like very early tumors, again that we can discuss in clinic. We may offer only 5 days of radiation also. So it's safe, effective and important. I hope you like the video and get some information, general information. But again, detailed information or patient specific information cannot be shared or cannot be given in the general video. We can always discuss those with the clinical file and all the details in the clinic or OPD. Thank you so much for listening.